for maternal-fetal medicine in this lecture in our research series on cohort studies. Dr. Bailit is a tenured professor at Case Western. She trained for residency at Northwestern and did her Robert Wood Johnson, her MPH, and her maternal-fetal medicine fellowship at UNC. She was also a Warher Scholar and is currently actively involved with the Ohio Perinatal Quality Collaborative and is PI on multiple projects and has published over 50 peer-reviewed articles. I will turn the mic over to Dr. Bailit. Thank you.
Well, thank you, everybody. I appreciate you coming and hopefully eating your lunch to learn a little something. So we're going to talk about cohort studies today, and you know, these are fairly dry topics in the sense of we're talking about epidemiology and definitions and understanding what tools to use when. I promise there will be time for questions at the end. I am from the East Coast. I talk quickly, and so typically I have some time at the end of the presentation. However, if you have a burning question, please speak up in whatever way appropriate, and we will get your questions answered. Okay, so our objectives today are to understand the strengths and the weaknesses of cohort studies, to understand what research questions are appropriate for a cohort study, and then let's talk a little bit about data sources and which ones to pick and why. Core definitions. The key to understanding a cohort study is understanding exposures and outcomes. Exposure is what happens to you, for example, unprotected sex. The outcome is the result, and usually a health outcome. Sometimes can be economic, there are other kinds of things, but for the kinds of studies that most of you are going to be doing, these are health outcomes. And the example would be pregnancy. So the way to think about this is you have a patient, she undergoes an exposure of some sort in some setting, and then you measure the outcome. Now, a cohort, what does that mean? A cohort is literally a Roman army group. And the way I like to think about this is a cohort is a group of people marching forward in time, and you see what happens to them. So you have a group of soldiers, they march through a battle, that would be the exposure, and the outcome is how many are left. So the group for comparison are chosen based on the exposure. All right, so you have, for example, two groups of soldiers. One goes into battle, one doesn't. If you choose to do a study that's based on what the outcome, did somebody have a C-section? Well, C-section is a bad example because C-sections get complicated. Let's pick another one. Does somebody have one kidney or two kidneys? That's an outcome, potentially, if you're looking at exposures in early pregnancy. Then that's a case control study. So when we go back to, let's see if it's on my next slide, right. So in a cohort study, you have patient has an exposure, and in the comparison groups, you have patients with no exposure, and you look to see the outcomes between the two groups. If you were looking at outcomes, which patients had outcomes and which patients didn't have outcomes, and you look backwards to see the characteristics of the exposure, that would be a case control study. So the appropriate question for a cohort is, do outcomes differ between people who are exposed and not exposed? Now, here's one of those little rules that you just got to remember. You cannot have the outcome at the time of exposure. And that's important because the part of the strength of a cohort study is that sometimes you can infer things you cannot prove, but you might be able to infer things about exposure, about causality. And so understanding that your exposure came before your outcome is a critical piece in setting up a cohort study. So timing of a cohort is typically prospective, right? Remember our Roman soldiers, they're marching forward in time. Now, there is such a thing as a retrospective study, a retrospective cohort, and that's when your data is complete for your exposure and for your outcome. You know that your exposure temporarily came before your outcome, and you're just analyzing it as if you were moving forward. So you may already know the outcome in the data set, but you personally don't necessarily know the outcome, and you essentially are doing a prospective analysis as if you're moving forward in time, but you happen to have all the data at the same time, so that's a retrospective. That concept's a little bit hard, and when you look at one of my favorite tests is to review abstracts for the SMFM, and people will also often misclassify whether it's a retrospective cohort or whether it's a case control. That's important to be able to tell the difference for. That's where people get mixed up a lot. So again, cohort study, you have your patient, a group of patients, they have an exposure versus no exposure, and then you're measuring the outcomes in the two groups. Now, exposures can be tricky to measure. They may be random or non-random. If exposure is random by investigator instigation, that's not a cohort, that's a randomized trial. So cohorts and randomized trials are very similar, except, and the difference is, did the investigator cause the exposure or not? If the exposure is just what happens naturally, that's a cohort. If the investigator says, okay, this group's going to take drug A, this group's going to take drug B, that's done a randomized trial. So when is a cohort design useful? It's excellent for rare exposures. And that's because of the rule, no outcome at the time of exposure, then you can then associate temporal sequence, you can establish it. You just have to be very careful of this in a retrospective cohort. Just because it's all in the data set, you still have to follow that rule, and you have to know, either because of biological implausibility or something else that you know about that data set, that the outcome did not exist at the time of the exposure. And it allows the study of multiple effects of one exposure. And we'll talk about some examples in a minute that will give you a better flavor for that. It also allows direct measurement of the influence of disease in the exposed and the unexposed groups. And that's helpful sometimes, too, if you're counseling patients. So I've talked about all the rah-rah, what are the great things about a cohort study. There are some disadvantages and some weaknesses. It's often you need large numbers of people, and that is bad for rare diseases. It is very time-consuming if you want to follow people over a significant amount of time. That depends on what you're studying. And that's mostly bad because large numbers and lots of time equal expensive. And for those of you who've had NIH funding, you always know that money is tight and they have limits on how long those grants last. And so that makes sometimes long-term perspective outcomes very difficult to measure. So you need to ask appropriate questions of our studies and pick the study design type that is best designed for your research question. And please, 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 know what has previously done. Do your literature research. Right? The sign that should be in everybody's lab is thank you for not doing research that has already been done. You would be surprised how many people think they are creating something new and novel and it's been done 1,000 times, or it's been done before PubMed existed. Sometimes you see stuff and people only go back as far as their search takes them. So do a thorough search. Make sure that the questions you're answering haven't been done already. There's plenty of low-hanging fruit for new stuff. So good questions for cohorts. As we've said, they're good for rare exposures. And these are some examples. What are health outcomes in people surviving Hiroshima during the atomic bombing compared to non-radiated exposed people? And then you can measure the full range of health effects from the exposure. So an example of that, of people who took OCPs in the Framingham study, you can look at breast, ovarian cancer, you can look at MIs, you can look at a variety of outcomes when you have a known exposure. And then again, you can get incidence groups. So for example, helpful things to know, what are the thyroid cancer rates in survivors of Hiroshima during the atomic bombing compared to the non-radiated exposed groups? Okay, so what are the pitfalls in cohort studies? You have to choose and measure an exposure. You need to determine and define an outcome, and you need to understand your loss to follow-up. So I'm in trouble speaking today. Assessing exposure. Make sure that you have enough exposed individuals. You need to do sample sizes which take into account both the numbers and your effect size. You need clarity of exposure. So for example, some things are just yes, no, that's easy. But for many kinds of things that MFMs or doctors want to study, we need to know the dose that they took, the timing of the dose, the length of exposure. These are all important things, especially when we're looking at pregnancy and thinking about exposure in various stages of development. You also need to be sure that the control group is appropriate. The control group cannot be exposed. They have to be similar in all of the ways that you can possibly find, but they cannot have the exposure. And you have to have the exposed and non-exposed. You have to have a certain amount of surety in your data source to be sure that they're not overlapping groups. Again, you need to have a clear definition of an outcome. Some things are very easy. Are you alive? Yes or no? Probably one of the simplest ones to measure. But let's pick another one that might be important. Fatigued or not fatigued? Well, it's important to the patient, certainly, but it may be less clear due to data quality or inherent characteristics of the outcome. So, for example, fatigue is not recorded in medical records reliably. How many of you have seen third trimester women who are tired? That doesn't make it into your note for the day. Fatigue also means different things to different patients. And so there's sort of an inherent variation in what the definition of fatigue means, and there's certainly variation in how often it's recorded and where it's recorded. There's also intensity of exposure. Exposed and non-exposed groups should be assessed equally. So how do you determine the exposure? Is it self-report? Is it direct observation? You need to sort of understand the exposure. And then determination of outcome. So a good outcome is exposed and unexposed groups visit the physician who's aware of the exposure, who's unaware of the exposure, and assesses for the outcome. So the physician's blinded, and they are looking at all people equally to see if they have the outcome. A bad outcome definition, for example, would be the exposed groups examined by a physician, but the unexposed group outcomes are determined from medical claims stemming from the treatment of the outcome. So you get an inherent bias from the data in assessing the outcome. Loss to follow-up is also important. So it may depend on the length of time from the exposure. Longer is a harder study to do, but too short may miss the outcome. So for example of that is if you're looking for cervical cancer, 1 year after HPV exposure is not going to be helpful. And it may bias findings because incomplete data can lead to over or underestimation of the effect size and the direction. Let's give some examples of that. I'm sorry, before we do the examples. So other cautions for cohorts are exposures and outcomes properly categorized. You have two kinds of misclassification. There's random misclassification, which will make the two groups appear similar when they may not be. And then there's non-random classification, and that may over or underestimate effect size, and that's bias. And so you really you need to be, I think, in some ways more wary of the second one than the first one. Again, loss to follow-up may also over or underestimate effect size. And the classic example of this are the initial studies for Sheehan syndrome. So the doctor who is interested in the effects of major hemorrhage sent out questionnaires to people, and he got a bunch back, and he noticed that he had a bunch of people who didn't send anything in. So being a good student of epidemiology, he followed up with those patients, and I forget exactly what he did, whether he went to their houses or called a relative, I forget exactly what it was. But he tracked those people down who hadn't put in their surveys, and what he found is those people were sitting vegetating at home because their thyroids were so low that they were just non-functional. And that, in fact, was the important part of the people with the bad hemorrhage outcomes. So had he not been meticulous at understanding the bias of loss to follow-up data, it would have looked like there was no difference when in fact there really was. One of the things we can do in a cohort to understand our data a little bit better and to have more confidence in our data is consider calculating the effect size if all of the loss to follow-ups had the outcome, and then again if they didn't have the outcome, to understand how big an effect your loss to follow-up group is having. Does it sway your answer? So your ability to perform a cohort depends on the quality of the data. So let's talk about a couple of different data sources. There's vital statistics data. That an example of that would be birth or death certificates. There's databases. Many hospitals keep databases of their own patients, for example. There's abstracted data, which is a variation on chart reviews. There's interviews with a person, and then there's direct observation of the exposures and the outcomes. So what are the pros and cons of vital statistics data? The pros are, at least in America, it's complete for the population. 99 point, I forget exactly, but 99 point something % of the population deliver in a hospital and have a birth certificate. And so you get a lot of data from them. Some items are very accurate. For example, birth weight down to the gram is very good. However, in birth certificate data, there are some things that aren't good. For example, the medical detail is lacking. Typically, medical detail is specific but not sensitive. So, for example, if you have somebody who's coded as having had an eclamptic seizure, there is a very good chance that that woman really did have an eclamptic seizure. If there's nothing marked for eclamptic seizure, you're not sure if it happened or not, because it is specific but not sensitive. Let's talk about databases. It's similar to vital statistics data, but more accurate with medical details, typically depending on how that data gets in there. Some databases are medical records dumps, and if you don't know what you're doing with that, that can be just a hot mess in terms of understanding your data sources. We found that in the Safe Labor Consortium. We thought, oh, this will be great. We'll get all these places together. Everybody will download the data from their medical records, and we'll put it all together, and we'll have this huge national cohort. Now, we do have a huge national cohort. It worked out great, but I don't think any of us realized in creating the Safe Labor how much work it was going to be to say, okay, well, we record this item in this place, and you record it in that place, and so to match it all up in the data set so that you've got every variable has the correct sourcing from each data set is very difficult. So be careful when you combine databases and know how you got the data into your databases. Chart abstraction is very different. Is your secretary doing a chart abstraction, or is there a trained nurse or a trained doctor, somebody with medical background going through those charts obsessively? Electronic medical records, again, sometimes better, sometimes worse than written records. And then direct observation is really the gold standard. Somebody specifically was looking for something and found it by direct observation of the medical environment. So again, I guess I've made this point already, but the pros and cons of abstracted data, it depends on the source of abstraction. If it's direct observation, if it's electronic medical record, is it a nurse abstractor versus a secretary abstractor? There are levels of goodness. How about patient interviews? In some ways that seems very similar to a direct observation. The problem is that patient interviews have recall bias for exposure, especially if it's a long time ago. They may have lack of detail to the exposure that is really needed. So do they remember the dose that they were taking? Do they remember exact timing of that? Do they remember whether they took it during the day? Did they take it during the night? And it may not be something the patient took, but something she was exposed to. So that's an important detail that you may or may not use in patient interviews, especially depending on the length of time from the outcome to the exposure. And then outcomes may not objectively be judged by patients. You're much better off having a third party observe than having patients self-report. As we know, some patients are more tolerant of health outcomes than others. So the classic example of this, you've got somebody eating, let's say, number of cheeseburgers eaten in a typical month, 3, no, I'll put down 4. And the other classic example we see of this is not only eating, but alcohol or drug intake. People tend to minimize their exposures. So what are the pros and cons of direct observation? Even if it's gold standard in terms of the best quality data, it is very expensive to do, and in many ways it's so cost prohibitive that we rarely see this kind of data. Why does the data source matter so much? The ability to know that your control group, your unexposed group, is the same as the exposed group. You need to have your confidence in your classification and confidence in follow-up being complete. Those 3 items are the things that make or break a cohort study. So that's why understanding your data source well really matters. Okay, so context. Let's understand the pitfalls in measurement with exposure or outcomes. So, example, the patient lived in an area with high levels of air pollution on census data. Well, that's great. You could say this patient lived in the census or she didn't. But are you sure how long she lived there to be able to estimate the dose? Did they spend time away during the summer when the air quality was worse? In other words, getting the detail of the exposure, even if they're in a high pollution area, you may still want more granularity than you're getting. And it may be different within the exposure group. So another example here is assessing the effect of drug X on kidney development. And your outcome is patients with one kidney. Now, in your data set, not all people had imaging to be able to determine outcomes. You just know about the ones who had imaging, and you don't know about those people who are happily living without ever knowing they have one kidney. So that's going to bias you towards thinking about your outcomes. So this is not to say that you don't go ahead and do the study. Sometimes you get the best data you can get, and you go ahead with it. But you need to interpret the results in the context of your confidence in the data. You can't just say, I had a randomized trial, or I had a cohort, therefore it's excellent data. You have to understand the nuances of your data source and how you selected your exposures and outcomes to know how strong that study is. There's a wide variety of strength even within cohort studies. The bottom line is garbage in equals garbage out, no matter how brilliant your hypothesis is. Okay, Journal of Fake Epidemiology. Journal of Fake Epidemiology. Let's take a look at some of the studies here and see what we think. Okay, so question. Do babies born prematurely have higher rates of mental illness? The data source was the Swedish Population Registry. The exposure was gestational age of delivery, documented on birth certificate based on ultrasound. The outcome was uniformly assessed by neuropsych testing at age 18 upon evaluation for armed service registrations. I want everybody to just spend a minute, think about whether they think that's a good exposure, is that a good outcome, maybe even write it on a piece of paper that you don't share with your colleague, and then share with your colleagues. I'll give you guys a second to do that. So I will say that this is an excellent study for a cohort. You have birth certificate data, which again can sometimes be suspect, but you're using variables from the birth certificate data, which are usually pretty good, i.e. gestational age, and you also know whether that patient had an ultrasound or not. So you know that the gestational age is probably pretty well determined. And then you are uniformly assessing everybody at the age of 18 in the entire population with formal testing. Whether or not they go into the armed services or not doesn't matter, but everybody was tested, and you're looking at that whole population that was tested, not just those who were enrolled in the army. So I think that's a pretty good study design. You have a good control group, and you can assess for loss to follow-up rates because you know how many people showed up for the evaluation of armed services registration. Okay, let's give another example. How do cesarean rates compare between midwives and MFMs? And you're going to use birth certificate data. The exposure is the delivering provider, and the outcome is a primary cesarean delivery. So again, I'll give people a minute to jot down their thoughts on whether this is good or bad, and then we'll talk about what's good or bad. Okay, so it's a bad design, and that's partly because the patient risk factors for cesarean differ between the midwives and the MFMs, right? So midwives and MFMs don't see similar groups of patients, typically. And you also have poor exposure and outcome ascertainment. So for example, midwives don't do cesareans, and you can't estimate easily from birth certificate data, certainly, who managed the labor. All you know is who did the final delivery. So therefore, your outcomes are confounded. Okay, next one. Do women with an induction of labor have a higher cesarean rate than those in spontaneous labor? Hospital database is from chart extraction is your data source. Your exposure is induction of labor from the medical chart, and your outcome is primary cesarean from the medical chart. And this one's a little bit harder. So what do people think of this one? And I will tell you that these studies were done multiple times by multiple people with similar answers in our profession's history. So this is really a bad control group problem, right? Because women who go into spontaneous labor are different from those who need an induction of labor. And so your exposure groups are just different groups of people. So how would we do that better? So the way we would do that better is for women at 39 weeks, does induction of labor have an increased cesarean rate compared to those who are expectantly managed? You would need prospective data collection by a nurse, and your exposure would be the elective induction at 39 weeks versus those who are eligible for elective induction but did not have the induction. So your exposed and unexposed groups are similar in every way except the exposure to induction. And then your outcome could be primary cesarean rate. It's better. The comparison group is the same except for the exposure. And why typically did this study not get done first? Because it's clearly a better study design, and that reason is cost. Now we're starting to look at some of the stuff. The MFMU has got a study with this design ongoing now. And so we'll know a whole lot more. But these studies take a lot of time and a lot of money, and therefore aren't necessarily the first ones to get used. When we did database work on these kinds of things, the first answer was, well, that elective inductions from that first study design, which we're saying is not a good one, the answer was elective inductions have higher rates of cesarean. And then some better designed cohort studies trying to figure out who was elective induction, so define a low-risk population, so those who would have been eligible for the elective induction, who got induced and who didn't among that group, started to give some different answers, and we'll hopefully have some more data with the randomized trial that's going on now with the MFMU. But this is how cohort data can be either misused or evolved to give different answers depending on the study design and the exposure and the outcome groups. All right, so conclusions. Key things to remember, and then we're going to have a discussion about the examples and any questions that people come up with. A cohort is moving forward in time because groups are chosen based on exposure. Rare exposures are the best for cohort studies, and you can assess multiple outcomes on that one exposure, and it allows you to get incidence data. And the quality depends on the control group, loss to follow-up, and your data source. And Mr. Osborne, may I be excused, my brain is full. So I'm going to stop there and let the group chime in, and we'll go from there. Thank you very much.
We are now open for questions. Feel free to type them into your Q&A box. I will let Dr. Bailit know. Any questions from the audience? What advice, Dr. Bailit, would you have for our incoming fellows who are just starting on getting a cohort study off the ground? What sort of timeline should they be aiming for?
So I think that the cohort really depends whether you're prospectively following patients or whether you're doing this from a database and you're really doing it retrospectively. Most fellow projects will typically be done as a cohort from a data set, so it's a retrospective cohort, which is time efficient during fellowship. I think the key here is just going back to basics. What is your exposure? How do you know what the exposure is? How certain are you of the exposure? And that the unexposed group really didn't have the exposure. And then again, same thing with your outcomes. How do you know somebody had the outcome? How sure are you of the outcome? I think one of the things that's helpful is putting together just the graphs and sort of the way I have. Here's the patient. Here are the characteristics of the patient. What's their exposure? How do I know? And then on the right-hand side, the outcome and the definitions. And then show that and explain it to people and see what others in your area see. That's one of the nice things about fellowship. You sort of have built-in peer group that you can bounce stuff off of. And bounce it by the people you disagree with the most, because you'll learn the most from hearing the opposite side of the spectrum. You know, and really making sure that you're defining it based on the exposure and not the outcome, and make sure that you understand that you've got a cohort and not a case control. That means going back to the book and the definition. There's nothing like a red flag to a reviewer when they misclassify.
Sorry for the ringing in my background.
Okay. I would say the other thing we can do is, if people have database studies that they are working on that they want to talk about now, to sort of see if they think, you know, get some group feedback on whether their exposures and their outcomes are correct and whether they're classified correctly. Where I'd be happy to hear about what people are working on, and the group can do some sort of free consulting on what the weaknesses are.
Feel free to type in your ideas, thoughts, current projects if you have questions for Dr. Bailit. I understand you are a board examiner, Dr. Bailit, so I don't know if I'm allowed to ask you this question, but for our graduated fellows who are now going to be defending their thesis, if they had a cohort study that they are bringing to the board, what sort of questions can they expect, and what must they know about their own studies while defending it?
I need to be thoughtful about how I answer that. So I, of course, can't give you the questions we would necessarily use. I think the first thing is to have run it by enough people to just make sure that you know what you're talking about and that you know the pros and cons, just the kinds of stuff that we talked about in the lecture today. And please, please, please make sure you've got your classification, that you've got this right, because it will be a red flag if you misclassify.
Excellent. Well, I think we don't have any questions from the audience today. Thank you very much for the thorough review. We look forward to seeing everyone again for the, oh, I see somebody who's raised their hand.
Okay.
For the individual who's raised your hand, there is a box on screen that you can type your question in. There we go. So the question is, what concerns should you have for a retrospective cohort over a long period of time?
So I think that the key thing there is making sure that your exposure predates your outcome, and that there can be no confusion about that. The other thing is, how is the data being collected in terms of your data source, so that you are sure that you have a complete group without a whole lot of loss to follow up. So I think those would be the two key things that would come to my mind first when you're looking at long exposure times. So for example, a long exposure time, think about DES. It took us a long time to figure out what that caused, because women had to come to reproductive age and understand their complications. That was a classic case control study. You had a rare outcome and you looked backward for the exposure. But understanding that there may be a long time frame, you have to make sure that you have complete outcomes.
To our fellows from UConn who asked the question, does that answer your question? Yes, thank you. Okay, well, we'll give everyone back 20 minutes to your day. Thank you again, Dr. Bailit, for the thorough review. We'll see everyone in a few weeks.
Thank you, everyone. Good luck. Bye-bye.
Bye-bye.